Over to you.
Thank you. Well, good evening to everyone. This is Dr. M.B. Agarwal from Mumbai Hematology Group. Today, we have Dr. Nitin Jain from MD Anderson as the guest speaker. And he's going to tell us all about chronic lymphocytic leukemia. And his lecture is entitled, very interestingly, as Future of Chronic Lymphocytic Leukemia Therapy is MRD guided, finite and combination oral therapy. So he's going to do that in about 30 minutes. We are grateful to Dr. Reddy's and Mike's ideas for handling this show. We are going to have question answer session after Dr. Nitin presents his lecture, and I request all of you to put in your question in the question box right from beginning, so that by the time his lecture ends, we have ample of them for him to answer. Before I hand over the platform to Dr. Nitin, I've been asked to tell you something about chronic lymphocytic leukemia in India. I'm going to begin with some cases. So these are cases that we saw about a decade ago in 2011. The one on the left side is the son and the one on the right is father. First, I'll tell you about the son. He was 39 years old. BNET stage A. He had deletion 17p. He was IgHV unmutated. His beta-2 microglobulin was high, so his IPI score was very high. His chance of survival at 5 years was 25%. Remember, we are talking about a decade ago when we had nothing except chemoimmunotherapy. This is father. He was 72. He was also BNET stage A. His beta-2 microglobulin was low. He didn't have 17p deletion. He did not have any TP53 mutation. His IgHV gene was mutated. His IPI score, therefore, was just 1, and that was because of his age. So his risk category was low, and his chance of 5-year survival was very high. So we saw both of them in 2011. This was before ibrutinib and venetoclax era. Son was treated with FCR. However, he relapsed within 18 months. He was transplanted. However, he relapsed after that within 6 months and then succumbed. Overall, he survived for 2.5 years. Father, as of now, is 81 years old. Is still asymptomatic, is not needed any treatment, and his disease has not progressed. What these cases do is to tell you two extreme pictures of CLL. One, father remaining asymptomatic for 10 years, and son having a very aggressive disease and dying very soon. I'm now going to put my third case. This is a case seen by Dr. Nitin Jain as well. This is a Parsi gentleman who stays next to my clinic in Dadar. We first saw him at the age of 51 years, and that was in 2001, that is 20 years ago. He's now 71 years old. In 2001, when he was 51 years old and he was diagnosed, that was only for the counts. He didn't need any treatment. 11 years later, 2012, at the age of 62, he needed treatment and he opted for FCR. He was physically fit with no comorbidities. At that time, we had nothing except chemoimmunotherapy. You remember that. He relapsed in 2017. At that time, he was 68 years old, and we had an access to ibrutinib by that time, and he was put on ibrutinib. He was quite fine for about 2 years, but last year, he was 70, he developed Richter. We gave him 6 cycles of R-CHOP. He responded, but soon relapsed. This is the time when he visited MD Anderson. He saw Dr. Nitin, discussed various options, came back, and finally opted for CAR-T in Israel. He could reach Israel just before the lockdown occurred. He got CAR-T done there. After that, he was stranded there for a long period. He just returned to Mumbai last month, and just before coming, the Israelis did his PET scan, and he is in complete metabolic response. So this is the story of this Parsi gentleman from Mumbai, from the age of 51 years to 71 years, and a couple of lines of treatment, from no treatment to FCR to ibrutinib to finally R-CHOP for Istal and now CAR-T. Chronic lymphocytic leukemia is the commonest leukemia in the Western world, and the figures are that it accounts for over 30% of all the leukemias. However, it is the least common type of leukemia in India, and most of the series published show that this is just about 5% of the leukemias in the hospital setup. This rarity is not just restricted to India, it applies to all Asian countries. The lower incidence amongst Indians persist, even those who have migrated and their descendants in the West. The younger age of presentation of CLL in India is unfortunately associated with more advanced disease, aggressive course, and shorter time to treatment. In major cities like Mumbai and Delhi, the presentation of asymptomatic patients with either lymphocytosis alone or incidentally found lumps in the neck or armpit or groin is not unusual, and once again in published series has accounted for almost about 30% of patients. A good number of patients present in advanced stages with even marrow failure, and many other present with complications like infections or immune-related complications like ITP or autoimmune hemolytic anemia. Some even directly present with Richter syndrome. Financial constraints in India interfere with detailed workup and treatment. However, immunophenotyping by flow, which is the basis of diagnosis, is widely available, and the FISH test for prognosis is also widely available. Tests for TP53 mutations and IGHV mutation status have become widely available, but are restricted to the stand-alone labs. Most of the institutions or the hospital labs do not do this. Similarly, cytogeneticists of top quality are available in major cities, and they can do karyotyping for you. Although not essential, most of the patients somehow undergo bone marrow examination, and they also undergo imaging, and somehow they also undergo CT and PETs. These are not absolutely required, but it's quite common. When you see a patient of CLL, the question to be asked are, is the diagnosis right? And I emphasize this because in India, even a case diagnosed on flow cannot be easily accepted, and you need to look at the quality of the flow, quality of the lab, detailed workup, the report that has been issued to convince yourself that it is a genuine CLL, or else repeat the same from a good lab that you can trust. Does the patient qualify for the treatment? Not all. Assess the molecular heterogeneity, spatially at least do the workup for deletion 17p, TP53 mutation, and IGHV mutation. Of this, deletion 17p is commonly done by most of the people, which we see as counter references, but TP53 mutation and IGHV is a rarity in routine practice. Assess the tolerability of the treatment with respect to age, comorbidity, performance status, and define your goal of treatment in consultation with the patient and the family. In a young patient, the goals are different from an elderly frail patient. In a young patient, the goal is to achieve unmaintained long-term response, if possible, MRD negativity and eventual cure. And I must tell you that the MRD test by flow cytometry from peripheral blood and marrow is now available in good number of labs in this country. In elderly frail person, the goal is to achieve disease control with a tolerable regimen. And I think the emphasis on tolerable word, without bothering too much about complete response or MRD negativity, We don't much bother about that. There are 4 complications which should be looked for, prevented, and treated. CLL have extra risk of infection. Autoimmune disorders like ITP, autoimmune hemolytic anemia, and pure aplasia. Always this risk of transformation to digital high-grade lymphoma and second malignancy. You should rule these out before you concentrate on CLL. Infections are a commonest modality of death of CLL patients in India. CLL itself is an acquired immunocompromised state. Vaccination against pneumococcal infection, although available all around, is not routinely practiced. Yearly influenza vaccine in this elderly group of patients should be offered, but is not the routine practice. Even looking for their hepatitis B status, and if they are candidate, giving them hepatitis B vaccine is not widely prevalent. There should also be judicious use of antimicrobial prophylaxis, and there can be an occasional case, very occasional case, who may need intravenous gamma globulin if his IgG levels are very low and if he's getting frequent infections, and some of them are severe. Bendamustine is the most popular treatment in India today, and it does result in long-term risk of infections, and this must not be forgotten, and it is less realized. Tools at our disposal in India are, we have all the 3 alkylating agents, chlorambucil, cyclophosphamide, bendamustine. We have 2 purine analogs, fludarabine and cladribine, both have gone out of fashion. The steroids. We have anti-CD20 antibody, 2 of them, rituximab and obinutuzumab. Ofatumumab has been withdrawn. Obinutuzumab, unfortunately, only the innovative molecule is available and is exorbitantly priced, and hence most of the patients do not have an access to it so easily. And that will be a setback, as you will realize after Dr. Nitin Jain presents his talk. Novel agents, ibrutinib, we have an access to from last couple of years, and now we have generic ibrutinib, which has made it easier to administer to the masses. Even then, the cost of ibrutinib with generic comes to rupees 30,000 rupees a month. So it's not for everybody, but yes, it is for many. Tools that are not available to us are pentostatin never came to India. Alemtuzumab was there in India, but has disappeared. In any case, it's not any modern treatment for CLL. ACAL ibrutinib will be launched in India next month, and that will be a great news. There is no news about venetoclax being launched in India. Roche appears to have no interest at the moment, and that's a setback. And adalimumab or any other equivalent molecule is not available in India. Commonest and the popular regimens. Young, fit, with no comorbidities were being treated with FCR till bendamustine arrived. Today, FCR has become a rarity. FCRI, which I'm sure Nitin is going to talk about, is not practiced. BR is very, 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 very popular. Ibrutinib generic has become popular. It's just the beginning of it because generic just became available. But I suddenly see a surge of patients who are being put on ibrutinib. And of course, with COVID era, there is an interest of both clinicians and patients to go for oral home therapy. So ibrutinib is further picking up. Elderly, fit, with no comorbidities usually are treated by BR. Very old, unfit, and comorbidities are often treated without bendamustine. Chlorambucil is the drug of choice. Often it is used alone, and that's very popular. Of course, there are patients treated with chlorambucil and rituximab. Chlorambucil, obinutuzumab is not a popular regime in India. And use of ibrutinib again in this group is picking up after generics. FCR light has been used. I see the prescriptions all around. FCR light is FC dose reduced and rituximab escalated variant of FCR. It is effective and has better tolerance with respect to reduced grade 3-4 neutropenia. However, this data was generated from a single arm study and there is no phase 3 data. But this is more popularly used in India than FCR itself. BR therapy, of course, is left and right. It is used for across, everybody. Today with the government policy, rituximab is available at throwaway price, and bendamustine does not cost much, so BR is a regime all around. Benda is inferior to Fludara, it is superior to chlorambucil, but gels well with rituximab to give you an acceptable CR. And it is used in India both upfront and in relapse setting, left and right. In elderly persons, BR is superior to chlorambucil rituximab with a CR of 21% versus 7% and a longer progression-free survival of 39 versus 29 months. Interestingly, BR gives longer 5-year progression-free survival in women, and it causes more myelosuppression in women. I don't know the mechanism. Well, old is gold. Those of you who are of my generation know these actors, Devanand and Nutan. So, aged people, poor performance status, and comorbidities. Though chlorambucil obinutuzumab is an attractive combination, obin is beyond reach of many patients in India. Obin with chlorambucil has improved response rates and given prolonged PFS compared to both chlorambucil monotherapy and chlorambucil with rituximab. So should be a preferred option. Peculiarly, it had lower risk of death than chlorambucil monotherapy. Well, sequencing and molecular studies, impact of deletion 17p, TP53 aberrations and IGHV mutation. Significant impact because that totally changes your outcome. FCR and BR are poor choices for this group of patients and even detrimental because it can shorten the survival when you give chemotherapy to a patient having this mutational changes. However, good number of patients are being treated by BR without looking at deletion 17p or TP53 mutation. In fact, TP53 mutation looking up is very rare. People just do fish and stop there. Ibrutinib is the best treatment from the package that we have available in India, and there is current consensus on that. It gives much better long-lasting results than all other modalities we have availability in India. So it has become popular, especially with generic version. I conclude my talk by saying that in daily clinical practice, the goal of therapy must be defined before selecting a particular treatment strategy, because today you are very fortunate that you have huge number of them. When I was a student doing hematology, it was chlorambucil plus prednisolone. Then came FCR, then BR, and then ibrutinib and rest of it. Chemo is the standard of care for treatment of CLL in India for most. Addition of rituximab is synergistic and quite popular. FCR, FCR light, FCRI, BR, chlorambucil, rituximab, chlorambucil alone are various things which have been used depending upon the age, fitness, and comorbidities. Chemo-free treatment using novel agents is restricted to ibrutinib. It's an exciting approach because increasing number of patients now have an access to it. Ibrutinib can be used across the board irrespective of age, mutational status, TP53 status, FISH results, de novo patients, and relapse refractory patients. And we do see now patients who are being put on ibrutinib without basic workup. And that should ring alarm because that's not good practice. One must remember that chemo-free treatment does not equate to toxicity-free treatment. And I'm sure Nitin is going to tell us all about toxicity of these oral agents. A small fraction of patients in India do have an access to drug like venetoclax. There are 4 brands which are sold in Indian market, not through Roche, but through agencies who get you drugs. They ship them, they import them, and give you whenever needed. These patients are on venetoclax plus ibrutinib, and one patient that I shared with Nitin is a young man with deletion 11q and IGHV unmutated with a large abdominal mass, which was fortunately not Richter, and this patient is on ibrutinib venetoclax combination, following up with Nitin. is doing very well. So small fraction of patients for whom finance is not an issue, they have an access to venetoclax, obinutuzumab, etc. MRD assessment by flow cytometry giving a sensitivity of up to 10 raised to -4 in a reliable fashion is available in Mumbai and other places in India. And this is useful if your patient is on venetoclax, like the gentleman I just mentioned to you. It, however, serves no purpose if the patient is on ibrutinib, because you don't expect MRD to become negative. Well, that's all I have to tell you about CLL in India. And sorry for taking your time and keeping you away from Dr. Nitin. And it's now my pleasure to introduce Dr. Nitin Jain to you. He is professor in Department of Leukemia at the prestigious MD Anderson in Houston, Texas. His areas of research are put here as CLL, but I must, Dr. Nitin has already logged in, I must tell him that I have read his other presentations and other publications in other aspects of leukemia, especially I learned a lot by reading his research on PH-like acute lymphoblastic leukemia. He earned his medical degree from All India Institute of Medical Sciences, New Delhi, 18 years ago in 2002. He moved to US after that and did his internal medicine residency training at the Medical College of Wisconsin, Milwaukee. This was followed by clinical fellowship in leukemia at MD Anderson and then leukemia research fellowship in Memorial. He then pursued hematology oncology fellowship from University of Chicago. He joined Anderson back as a faculty in the Department of Leukemia 8 years ago in 2012. His clinical interests focus on new drug development for patients with leukemia, especially chronic lymphocytic leukemia and acute lymphoblastic leukemia. Dr. Jain is principal investigator of several investigator-initiated phase 1 and 2 clinical trials, including combination targeted therapy. What he loves, what is his baby, which he's going to speak on, is Ibru plus venetoclax in CLL and a trial of JAK2 inhibitors in PH-like ALL, another baby of his. He has published extensively in reputed journals, including JCO, Blood, Clinical Cancer Research, Cancer, Leukemia, Lymphoma, Leukemia Research, and many more. He has won many awards during his career. Some of these include Merit Award from the American Society of Clinical Oncology, High Impact Clinical Research Support Award from MD Anderson in year 2014 and in 2016, and Sabin Family Foundation Award 2 years ago in 2018. So I hand over the screen to Dr. Nitin, and his topic, as I mentioned in the beginning, is future of CLL therapy is MRD guided, finite, and combination oral therapy. So over to Dr. Nitin.
Hello, good afternoon, everyone. Good evening, everyone. And thank you, Dr. Agarwal, for that wonderful introduction. That's very nice of you. So the topic given to me, and let me share my screen. Give me a second here. Can you see my screen?
Yes.
Okay. Can you see the slide in the slideshow mode, or it's okay? It looks fine.
Can you make it full screen?
How about now?
Yes, excellent.
Okay, perfect. So yeah, so the topic Dr. Agarwal actually gave me, the future of CLL therapy is MRD guided finite combination oral therapy. I think it's a provocative topic, and I think it may not be true in the real sense. So I will go through the data, see what you guys think. My goal is to finish maybe in around 45 minutes or so, and then I think we'll have ample time for questions, maybe half an hour, maybe more, depending on the number of questions we get. So these are my financial disclosure, working with several pharmaceutical companies on clinical trials, and some advisory board participation. So as Dr. Agarwal alluded in his talk, certainly the field of CLL has moved quite remarkably from the use of single agent purine analogs, alkylating agents, to chemoimmunotherapy. And certainly, at least in the United States and most of the world now, the availability of targeted therapies including BTK inhibitors. Now we have 2 approved, ibrutinib and acalabrutinib. We also have zanubrutinib in the pipeline to be approved for CLL. We have PI3 kinase inhibitors, BCL2 inhibitor, very importantly, venetoclax, and then the role of obinutuzumab, a novel CD20 antibody. So these regimens really have changed how we treat patients with CLL. So at least in the United States, I would say that where up until recently, which maybe I would call a chemoimmunotherapy era, where the goal was to give FCR to young fit patients and then bendamustine rituximab or chlorambucil-based therapy to older adults. I think the field has changed to where, at least in our center, what we are doing is using FCR for young fit IGVH mutated patients only. And again, that's still a discussion, and I will kind of show you some of the data to that effect. I think target therapy may also be very appropriate for this patient population. But besides that group of patients, the young fit IGVH mutated patient, which constitute maybe around 10% of all patients with CLL, at least we see in our practice, the target therapies have really taken over as the standard of care for these patients, and really chemotherapy is not being used at all. So in our center, I guess I would say a small minority of patients, 10% or less, are getting chemoimmunotherapy, but majority of the patients are getting target therapies for their CLL. And in many centers in the United States and elsewhere, people have absolutely stopped using chemotherapy at all, and everyone is getting target therapies only. And we'll discuss some of these data again in the next 45 minutes. So this is a review I wrote with Dr. Susan O'Brien last year now. Basically, at least from the perspective of where we kind of stand in the US, the treatment paradigm for patients. And again, you can kind of review it, but I think suffice to say that pretty much every box in the frontline setting, you see ibrutinib, acalabrutinib, and venetoclax, which is combined with obinutuzumab, as an available option. And FCR is listed on the extreme lower left-hand side of the slide, again, for young, fit, IGVH-mutated patients. But I think other options may very well be appropriate options for this group of patients as well. So now, again, let's review the data for these agents kind of one by one. And I have divided this talk into kind of segments for young, fit patients and then kind of older patients. So for a young fit patient, and that's just a definition, I would say FCR eligible. So this is someone maybe 55-year-old, 50-year-old, 60-year-old, who is otherwise fit, good organ function, good kidney function particularly. And this is a patient you may consider for FCR in your practice. So in this regard, the first study was done by Dr. Keating at our institution here now 15 years ago. This paper published in JCO in 2005, where he reported a very high rates of complete remission for these patients who are getting first-line FCR. And these were the first 300 patients who were treated at MD Anderson with FCR. So that FCR regimen, trial generated a lot of interest. The German CLL study group subsequently did a very well-known study called CLL-10 study, where the goal was to compare FCR versus bendamustine rituximab in the frontline setting. And certainly BR is better tolerated. FCR has more myelosuppression, and the goal of the study really was to see if BR will be as effective as FCR with less toxicity. So this was the initial primary analysis, which was published a few years ago in Lancet Hematology by Barbara Eichhorst, where what they reported was that the FCR actually had improved progression-free survival compared to bendamustine rituximab, which was actually the primary endpoint of the study. So actually the study was in favor of FCR over BR, with the caveat that patients receiving FCR were more likely to get infectious complications, more likely to get myelosuppression. So I think, and also an important point there is that patients above 65 years of age, there was really no difference between FCR and BR, but certainly the difference was pronounced in less than 65 years of age with FCR. Now, this study was recently updated in the journal Hemisphere by the German CLL study group. This is now a median follow-up of close to 5 years for these patients, and where you see these long-term PFS curves with FCR versus BR. This is for all patients. And certainly, again, you see an improved PFS with FCR compared to BR, for this entire patient population. Now, notably, there is no difference in overall survival. So I think most studies in CLL, which I will show you today, have improved PFS, but very few studies have actually able to show improved OS compared to whatever control arm you're using. So again, no difference in the OS. And now, as I kind of alluded to before, the field, and at least our group and many of the groups are really thinking if you have to use FCR, or if you have to, for that matter, use chemoimmunotherapy, we should really use it for young, fit IGVH mutated patients. So in this update of the CLL10 trial, actually the investigators nicely put this curve in where it is the PFS by IGVH for only 65 years and less patients. So this is really the patient population you may consider chemoimmunotherapy in the present era. And I think this study provides a nice historical rate of what to expect with FCR. And I just highlighted a couple of numbers here, a 3-year PFS of 80% and a 5-year PFS of 65% in the young, fit, IGVH mutated patients if you were to give them standard 6 cycles FCR. And I think it's important to remember this number because I will kind of come back to it later in the talk as well. So 3-year PFS of 80% and 5-year of 65% if you're using frontline FCR. Now, a couple of important aspects, because Dr. Agarwal mentioned in his talk that bendamustine is used quite frequently in India. Certainly, that's true for most of the world, actually. Now, in this study, this long-term update of FCR versus BR, interestingly, and the infectious deaths, and I kind of tabulated at the bottom of the slide, for less than 65-year age group with BR, it was 4.7%. versus 0.5% for FCR. So quite a remarkable difference actually with BR versus FCR, and the ratio was flipped in older patients. So certainly I think above 65 years of age, really no need to do FCR. That I certainly would not recommend doing FCR. But interestingly enough, in the study, less than 65 years of age, there were almost 9 to 10 times 0.5% versus 4.7%. Infectious deaths, which were more in the BR arm compared to the FCR arm. Now, one thing certainly we worry about whenever we use chemoimmunotherapy for our patients, especially FCR, would be risk of therapeutic MDS and AML. And it was also nice to see in this large data set from the CLL10 trial, the risk of AML and MDS, and I've highlighted that for you in the table here. So again, if you are less than 65 years of age, the risk with FCR, the risk was 1.6% for MDS and AML, but above 65 years of age, certainly the risk increases, at least in this study, to 7%. So all the more reason not to really use FCR for above 65 years of age. I think less than 65 years of age, that's certainly a consideration in mind. Now, another large study which we should talk about before we really move into the target therapy is what is called the E1912 trial. This is the ECOG trial led by Tate Schoenfeld. They reported the data in New England Journal and subsequently was updated at ASH. And this is the data from the ASH last year. So this study was for young patients with CLL. Patients with deletion 17p were excluded. And what the investigators wanted to compare ibrutinib rituximab head-to-head with FCR. Now, notably, ibrutinib rituximab arm continue ibrutinib like lifelong, which is the standard, like as a maintenance in a way. But in the FCR arm, patients get 6 cycles of standard FCR and then they stop therapy. So this was the updated PFS reported by Dr. Schoenfeld. And what you see here, certainly the ibrutinib arm is superior for progression-free survival compared to FCR. This was the primary endpoint of the study and actually certainly looks favor of ibrutinib and really making a strong case for using ibrutinib over FCR. Now, when they subdivided these patient population by mutated versus unmutated, what was clear was that the benefit was largely seen in the unmutated cohort of ibrutinib, as is kind of you can see here. For the mutated cohort, the curves are kind of overlapping, and we have to see if they separate further out later, but at least at 3 years, there is no statistical difference between FCR versus ibrutinib rituximab. Now, curiously enough, and I think a bit unexpectedly, there was an overall survival benefit for ibrutinib rituximab arm versus standard 6 cycles FCR. And I think that's a bit, everyone I think was surprised to see that, because you don't really expect that in frontline CLL studies to see an OS benefit. Again, the caveat here is the number of events which are listed in the figure here are quite small. So I think one or two events more here and there can really change your p-value and can maybe negate the OS benefit. So at this time, the data as reported last year, shows a improved overall survival. I think I will be highly interested to see if they update the data at this coming ASH and how these curves look at that time. But certainly there's an OS benefit for ibrutinib rituximab. So then you may argue that, okay, that's great. You have a PFS benefit, you have an OS benefit for ibrutinib versus FCR. So that should be the end of the discussion about FCR. The only caveat here is that if you look at the deaths, practically all the events, the death events, occurred in unmutated IGVH. So for the mutated IGVH, I think among all the events, there were like one or two events only. So again, if you split the OS curves by IGVH status, the curves for mutated IGVH will be overlapping. The difference will really be seen in unmutated V-gene patients. Now, one of the quite interesting question when this data was initially reported or presented at ASH, the previous ASH 2018, was why these patients are dying. And initial suspicion was that they may be dying from FCR because of infection issues and whatnot. But actually what appears, and this is the causes of death, actually there were not many infectious deaths from FCR, and you can really see the deaths listed there. 4 patients had progression of their disease after FCR and somehow then succumbed to their disease. But there were no real infectious deaths or increased infectious death in the FCR group. So that's kind of somewhat of a background on the FCR and the regimens. But one of the questions we started asking ourselves, this goes back to 2014, 2015 timeframe, when I joined a few years into my faculty position here, discussing in the group with Dr. Keating, Dr. O'Brien, Dr. Vieira, and others, was which patients to benefit most from the FCR. Because at that time, ibrutinib was coming along. It was just approved by the FDA for relapsed refractory patients. And we were kind of thinking how we can incorporate these new agents in our FCR, and can we kind of modify the FCR regimen in some fashion. So the information we have at that time was that patients with IGVH mutated patients who get FCR derive long-term PFS benefit. And this is the data which Phil Thompson from our group reported some time ago, where you can see that if you look at the top curve, which is the IGVH mutated curve, almost 55% of the patients are progression-free at 10 plus years, and they are kind of in a plateau phase. And that's what has really led to this argument that FCR can potentially cure half of the patients who are IGVH mutated. And similar data with slightly shorter follow-up has also been reported by the German CLL Study Group and by David Rossi as well. So I think there is this thinking that IGVH mutated patients, you can potentially, half of them, you can cure them to say, or have a long-lasting remission with 6 cycles FCR. So what was clear to us at that time was that the patients who drive the most benefit are IGVH mutated. Certainly patients who have deletion 17p or p53 mutation do not benefit from chemoimmunotherapy. And I won't go into that, but the data is quite well established that we should not be using chemotherapy for those patients because the median PFS in the frontline setting is less than 1 year. And then another thing we have noticed was that if you have a strategy which can lead to what is called undetectable MRD, it's a way of saying MRD negativity. In the CLL field now, the terminology being used is UMRD, undetectable MRD. But if you have a patient who achieves that, then we also saw with the FCR, if you achieve MRD negativity, you will have better progression-free survival. So we thought, okay, how we can design a regimen? And this is what we came up with. We updated this at the ASH meeting last year, and now it's being submitted for publication. So we designed this regimen called ibrutinib FC obinutuzumab. We call this regimen IFCG. And I think it's important to note that this regimen is only for IGVH mutated patients. So very selected group of patients without deletion 17p or p53 mutation. So we argued here for the study that we need to get higher MRD. And how do we do that? So we made a couple of changes with regards to that. First is that we replaced rituximab with obinutuzumab based on the CLL11 trial, where obinutuzumab was superior to rituximab. So the new regimen has obinutuzumab, not rituximab. And the second was that we added ibrutinib to the chemoimmunotherapy with the goal of achieving higher MRD negativity. And this was previously shown in the Helios trial in relapsed refractory setting at that time, that ibrutinib could be safely combined with chemotherapy, and the combination leads to higher MRD negativity. The other important aspect was we wanted to get rid of the chemotherapy for 6 cycles. So and again, 6 cycles of FCR could be difficult to deliver. Certainly more exposure to chemotherapy may lead to more MDS AML risk. So we have decreased the chemotherapy from 6 to 3 cycles in this new regimen. So no patient in the IFCG regimens gets 6 cycles, only is 3 cycles. So this was a study at MD Anderson. Again, IGH mutated patients, we call it IFCG because of the previous name of obinutuzumab, which was GA101. So this is the regimen. Patients get 3 cycles of IFCG, and then they have a response assessment. And after that, they get 9 months of ibrutinib, or they get 3 or 9 months of obinutuzumab, depending on the MRD status. But I think the important thing to remember here is there is no 6 cycles of chemotherapy. Everyone at max gets 3 cycles. And the other important aspect is we did not want to have a regimen which will be a lifelong ibrutinib regimen. We wanted to have a time-limited regimen for these patients because these are young patients. Someone is 55-year-old. You don't want to develop a regimen where you will give the ibrutinib for the rest of their life. So we want to have a time-limited regimen. So what we designed the study is that if you are bone marrow UMRD, so if basically bone marrow MRD negative, at 1 year mark, patients will stop ibrutinib. So our goal was that hopefully we can get a time-limited regimen for these patients for 1 year with only 3 cycles of chemotherapy with FC. So we treated 45 patients in the study. This is just the baseline characteristics. Again, just to kind of highlight one point, these are good risk patients. So what you see here, if you look at the FISH column, 69% of these patients were deletion 13q. So again, these are good risk patients who are being treated in this study. And I will compare a bit later IGH mutated patients only with different FCR regimens and IFCG regimen, just to kind of give you a comparison of how these data do. So this is our best response on an intent to treat analysis. So in fact, 44 out of 45 patients achieved bone marrow MRD negativity in the study, so on the rate of 98%. In fact, there was only one patient who did not achieve MRD negativity because he received the first day of obinutuzumab, he had an infusion reaction, and he was basically taken off study and never resumed anything on the study. So on an intent to treat analysis, that patient was obviously called as having not achieved a response, though he was just on the study for 1 day. Rest of all 44 patients achieved bone marrow MRD negativity on the study. This is the same data. On the left side, you see best response, which I just showed you. And then every 3 cycles of the first 1 year, we had response assessment in the bone marrow. So I'm talking about bone marrow MRD. And what you see here is very high rates of bone marrow MRD negativity for these patients. Now, the question in your mind will be, okay, that's fine, but how does this compare to FCR? That's what we are more familiar with. How does this data compare with FCR? So to compare equally, what I list in this table is bone marrow MRD negativity for only IGH mutated patients after 6 cycles, because we have lots of data with 6 cycles of FCR. So to compare equally, I list only IGH mutated patients after 6 cycles of FCR. What you see here is the first 4 studies are FCR, straightforward FCR studies. First 2 are from MD Anderson, and then is the German CLL study group trials. If you look at either the evaluable patients, evaluable means who had a bone marrow assessment done, or intent to treat, where you pretty much take all comers as the denominator, all patients as the denominator. It's fair to say that among the evaluable patients, half of the patients get MRD negativity, and on intent to treat, maybe 1/3 of the patients get MRD negativity. Now, there also has been what is called a green trial, where R was replaced with G, so FCG. And what you see here is that surprisingly, not a substantial improvement in MRD over standard FCR, what you can see here on the table. Now, Matt Davids at Dana-Farber, he reported on IFCR. So important difference in IFCR is that patient gets 6 cycles of standard FCR and ibrutinib is added on top of it. What you see here is, yes, this regimen does lead to high rates of MRD negativity, both among the evaluable and intent to treat analysis. And the last one here is the IFCG study. If you look at the 6 cycles of the IFCG study, the results are actually quite promising. What you see here, either evaluable or intent to treat, very high rates of MRD negativity, despite the fact this is the only regimen using 3 cycles of chemotherapy. All the other regimens listed here use 6 cycles. So to us, that appears quite promising in terms of the depth of remission, the number of patients getting MRD negativity with this regimen. This was the progression-free and overall survival. We have now updated this curve actually, and the curve is the same with no patients having CLL progression on the study. The one event is an early death on the study without progression. So you may be wondering, that's great. The IFCG curves PFS curves look pretty good. So our 3-year PFS is 98%. How does that compare to FCR? So I think the only appropriate comparison will be 3 years of PFS. So again, if you look at the CLL10, if you look at the E1912, again, looking at the FCR cohort for IGVH mutated patients only, it's fair to say that with FCR, you get a 3-year PFS of around 80% if you're using standard 6 cycles FCR. And now with the IFCG regimen, with 3 cycles less of chemotherapy, we are, again, in a small number of patients, we are 98% at 3 years. So to me, that looks favorable. Certainly we'll have to follow up these patients longer and have larger number of patients in this clinical trial to make that point. Now, kind of moving forward for the older patients, which is really the most of the patients you will see in your practice. So this is the study for older patients, the RESONATE-2 study, which is the study which led to ibrutinib approval in the frontline setting, ibrutinib versus chlorambucil frontline study. Now, this is a recent update, 5-year update. Again, chlorambucil arm doesn't really matter in a way, but really, as you can see, a remarkable difference. And ibrutinib, the 5-year PFS is 70%. So that's an important number to remember, which I tell patients when they ask me as they're starting ibrutinib, that the expected 5-year progression-free survival with single-agent ibrutinib in the frontline setting is 70% on all comers. Interestingly, in this study, in this long-term follow-up of the RESONATE-2 study, if you look at the ibrutinib curves by mutated versus unmutated, there appears to be some separation towards the end. We'll see if that holds up with longer follow-up. But again, suffice to say, both the mutated and unmutated are doing very well. And the investigators also noted overall survival in favor of ibrutinib versus chlorambucil for these patients. So certainly, I think this makes a point of using ibrutinib over chlorambucil, again, if finances is not an issue. Another important study for the field was what is called the Alliance study, led by Jen Voyak, which was reported in New England Journal. And here, older patients were randomized to bendamustine rituximab versus ibrutinib rituximab. So again, a very appropriate comparator, because you may criticize the other studies of using chlorambucil or chlorambucil obinutuzumab as a comparator. But here we have a bendamustine rituximab comparator, which is probably one of the most commonly used regimen for older folks for CLL. And I'm sure you have seen this data where both the ibrutinib arms, with and without rituximab, were superior to bendamustine rituximab. So certainly making a point that if progression-free survival is your kind of endpoint in your mind for your patients, no question ibrutinib is better than bendamustine rituximab. And there is no benefit of adding rituximab over ibrutinib. So we, in our practice, if you have to use ibrutinib, I use ibrutinib as a monotherapy. I never really combine it with rituximab or obinutuzumab. Notably in this study as well, there was no OS benefit. So again, OS benefit is hard to prove, hard to say in CLL studies, because it may take a long time, if at all there is a benefit. Importantly, we recently heard results with acalabrutinib. So that's called what is called the ELEVATE-TN study. So acalabrutinib is another BTK inhibitor, targets C481S, and is currently approved in the United States. And I heard from Dr. Agarwal's talk that it will be coming in India as well, I guess, next month. So in the frontline, patients were randomized to acala obinutuzumab, acala alone, and obinutuzumab chlorambucil. And this is what Jeff Sharman reported at ASH, and subsequently, I believe the paper is published in Lancet, where the G chlorambucil arm is certainly inferior. You can see the PFS at 2 years is 47%. But what appears to be that there is a slight 6% difference between the acala alone versus acala obinutuzumab arm. So that has led to the argument that maybe with acalabrutinib, we need to use obinutuzumab because you're seeing a 6% PFS difference, which actually, if you look at the hazard ratio, they did not cross 1. So maybe there is a statistical significant difference between the two arms. I would say that certainly that's approach you could undertake. However, we don't do that, at least I don't do that in my practice, for a couple of reasons. One is that adding obinutuzumab adds to myelosuppression. There is more neutropenia, more infusion reactions. And certainly the 6% PFS difference in my mind is not sufficient enough. And it's quite possible we may lose that difference with a longer follow-up of this trial. So I'll be quite curious to see a 3-year update of PFS of these two arms. And again, maybe we'll see that at ASH, but that'll be quite interesting to see if the curves continue to separate further or they will merge together as the time goes by. So this is just some of the major AEs to say, just highlighted the atrial fibrillation. It does occur with acalabrutinib, though appears in a cross-trial comparison to be less than what we have seen with ibrutinib. So this is all great, right? Ibrutinib, acalabrutinib, all these BTK inhibitors are leading to impressive PFS in the first-line setting, but there are some downsides to using these therapies. First is that these are indefinite therapies. So some of the side effects can tag along, can increase, such as hypertension. Second is certainly one is the cost, and especially in the perspective of India, where they have to be on ibrutinib or acalabrutinib now for the rest of their life, and it's quite expensive. And these therapies do not lead to a complete remission rate in the majority of the patients, and MRD negativity is practically rare or unknown with these drugs as a single agent. And the excitement in the field is time-limited therapies, time-limited target therapies to say, where you give combination therapies for 1 to 2 years and then achieve high rates of CR, high MRD, and then you're able to stop therapy. So in that regard, one of the first trials is what is called the VENG trial, or CLL14 trial, I should say, where older patients were randomized to chlorambucil G versus venetoclax obinutuzumab. And this was a time-limited therapy of venetoclax for 1 year. So this was the PFS curve from ASH last year, updated PFS curve, where certainly venetoclax obinutuzumab is superior to chlorambucil obinutuzumab, and the 3-year PFS with VENG was 82%. And again, but one point you have to remember here is that the patients stopped therapy at 1-year mark. So the PFS curve you're seeing at 3 years, these patients have been off therapy for 2 years. Now, one thing which was noted was, and again, this has to be studied in a larger number of patients, is that for patients who are deletion 17p or p53 mutated, which is the second curve from the top, you see that there is a stepwise kind of progression after stopping the therapy at 1-year mark. So this has led to this concept that for deletion 17p p53 mutated patients, venetoclax obinutuzumab may not be the answer. We need to do something more for these patients because, as you can clearly see, after 1 year, these patients are continuing to progress. So for these patients, I would say that I would be more in favor of using a BTK inhibitor than a venetoclax obinutuzumab-based regimen, just because of what we are seeing in this figure here. Certainly, venetoclax obinutuzumab leads to high rates of MRD negativity, which is not seen with BTK inhibitor strategy. One thing, if you're going to use this regimen in your practice, is that think about neutropenia. Half of the patients will get neutropenia, grade 3 or 4 neutropenia, and this is something you have to check their blood counts, give them growth factor support. Sometimes we have to decrease the dose of venetoclax for these patients as well. So now I have told you about two kind of major regimens in a way. We have CLL14 with venetoclax obinutuzumab in the frontline setting. We have RESONATE-2 with ibrutinib in the frontline setting. We also certainly have acalabrutinib, but the follow-up is a bit short. If you look at the 3-year PFS for these two studies, VENG or ibrutinib, quite remarkably, both studies have a PFS at 3 years of close to 82%. And there are some differences again in these studies, but actually, it appears that the group in the CLL14 may be slightly more comorbid patients because they have a higher comorbidity index compared to the RESONATE-2 study. And also to note that in VENG at 1 year mark, patients have stopped the therapy, unlike ibrutinib where they're still continuing on it. So to me, that looks quite favorable, I guess in some sense in support of VENG, because at 3 year mark, you're achieving the same PFS as you would have achieved with ibrutinib therapy. Now, what we don't know is that what will happen 5 years of follow-up with VENG. We know with ibrutinib at 5 years, 70% are progression-free. Whether the same thing will be achieved with venetoclax or venetuzumab, I think that remains to be seen, and obviously time will tell in the next 1 to 2 years if that happens. So the available frontline therapies at least in the United States are ibrutinib, acalabrutinib, venetoclax, or venetuzumab. These are kind of, I list here pros and cons of these approaches. And these are certainly, it's kind of on a daily basis, I discuss with the patients who are asking for new therapies for their CLL outside of a clinical trial setting. I think all these approaches have pros and cons as is listed. And it's important to discuss this with the patient and then kind of come up with an appropriate regimen for them. Now, one other regimen which certainly our group and many other groups have worked on is the combination of ibrutinib plus venetoclax. And one of the rationale, besides the preclinical rationale, is the clinical rationale, where if you look at ibrutinib, it really does not clear the bone marrow very well. However, if you look at venetoclax, it really rapidly clears the bone marrow for the patients. And because their side effect profile is different for these two drugs, we argued that they could be safely combined together for patients with CLL. And again, there was a preclinical rationale from our group and other groups as well that in the lab, there was a synergy of combining ibrutinib with venetoclax. So we have subsequently done a study combining ibrutinib and venetoclax for first-line therapy of patients with CLL. This study also has a relapse refractory arm. We have treated a total of 200 patients at our center on this study. The study is fully accrued and is now close to new patient entry. And we have reported the data on the first 80 patients of the frontline cohort. Again, this is a study where it's for high-risk frontline patients. So not everyone is allowed. You have to have some of the high-risk features to get on the study. Ibrutinib is given for the first 3 months, followed by venetoclax. So the 3 months of ibrutinib is more for tumor lysis reduction. And then you add venetoclax, and then both drugs are given together for a total of 2 years. And at that time, venetoclax is stopped, and then if you're MRD positive, patients can continue ibrutinib until disease progression. So these are the baseline characteristics of the first 80 patients. Again, if you look at this group of patients compared to what I showed with the IFCG regimen, this is a higher genomic risk group of patients. In fact, if you look at the bottom of the slide, 92% of the patients had either an unmutated V gene, a p53 aberration, or deletion 11q. We reported the results of this study in New England Journal last year. These are the response rates we reported at that time. But we have an update. We updated the data for ASH last year, and we have submitted an abstract this year for ASH as well. But this is from ASH 2019, where among the first 80 patients, 60 patients out of 80, so 75% of the patients achieved a bone marrow MRD negativity as their best response. So this is with 2 oral drugs together. So that looks quite remarkable, where you're able to achieve high rates of bone marrow MRD negativity without the use of IV strategy to say like obinutuzumab or rituximab with 2 drugs alone. And serially, if you see the figure, you see that as time goes by, with the combination, you see more and more patients achieving MRD negativity. In fact, one of the questions we wanted to address was that, is there an increment in the MRD between year 1 and year 2 of the combination? And at least what we reported at ASH, and we have a similar data, updated data for this coming ASH, where bone marrow MRD negativity improves from end of year 1 to end of year 2. So patients who are MRD positive at end of year 1, majority of them actually become MRD negative at end of year 2, making a point that there is a continual improvement in MRD with time with this combination regimen. Certainly, we are not alone in this regimen. So Captivate study is a large study which is being done with a very similar kind of design. In this study, also, newly diagnosed patients are given ibrutinib for 3 months, followed by venetoclax plus ibrutinib plus venetoclax. And in this study, after 1 year, there is a randomization based on the MRD status. We don't yet know the results of the randomization. What the investigators reported at past ASH meeting was what happens at 1 year of the combination of the two drugs together. So 1 year of ibrutinib plus venetoclax. And this is what they reported. So what you see here is that almost 70% of the patients, close to 70% of the patients, achieve bone marrow MRD negativity with this regimen. So again, and that results are very similar to what results we reported from MD Anderson in the single center study. So it was kind of gratifying to see that our results were very similar to this large international study with a bone marrow MRD negativity of close to 70% for these patients. So just very quickly, I made this slide actually some time ago after the ASH meeting because we had at the past ASH meeting, ASH 2019, we updated the data of ibrutinib venetoclax. We saw the data from Captivate with CONTAM, with venibrutinib. And then Kirsten Fisher reported CLL14 updated data. So we have kind of 3 ven-based frontline regimen, venibrutinib, and then also venobinituzumab. And if you kind of compare these regimens across, certainly there are differences in the genomic characteristics of the patient, the rates of myelosuppression. But if you look at undetectable MRD in the bone marrow on an intent to treat analysis at the bottom of the slide, that looks pretty similar for the 3 regimens so far. Again, I think it will be very important to see a longer follow-up of these 3 trials, hopefully at ASH this year, to see how these studies are faring in terms of progression-free survival. Now, I don't have time to go into there are many other trials which are happening, but I just wanted to kind of give you a flavor of triplets. So we talked about venetoclax or venituzumab, which is a doublet. We talked about ibrutinib plus venetoclax, which is a doublet. But now there are many trials which are looking at triplet. So you're using a BTK inhibitor, and you are using venetoclax plus venituzumab. So Ohio State reported at ASH a couple of years ago, triplet with ibrutinib. We heard from the German CLL study group, CLL2 GIFT trial, which is a triplet of ibrutinib in frontline 17P patients. We have a ACALA triplet, which from Dana-Farber at ASH last year, and we had a zanubrutinib triplet with the Vengi again at EHA this year. So all these are actually quite early on. So far, all these regimens, if you look at, they have a bone marrow MRD rate of 60-70% range. That appears to be similar to what we have achieved with doublets. So I think the big question in the field is whether you really need a triplet. Can you achieve the same results with the 2 drugs alone and you don't need the antibody? And I think that's something we don't know yet because all the triplet data is quite early right now. And again, we have to wait 1 or 2 years for these data to mature to see how the PFS curves are looking. Because as I said, it appears that the MRD negative rate is around 70 to 75% in all these studies, whether you're using a doublet or a triplet. And there are many other studies which are happening in the first-line CLL, phase 3 studies. You see many of them here, where I think this will really change how we further treat patients with CLL. If you look at the top study, the UK FLAIR study, where FCRBs randomized patients to ibrutinib rituximab, ibrutinib, or venibrutinib. Those are really important because you have a venibrutinib in a randomized fashion compared to ibrutinib. We have a CLL13 study looking at various venetoclax combination. We have a calabrutinib study with a triplet. And then we also have CLL GLOW study, which is trying to get a registration study of ven plus ibrutinib versus chlorambucil G, and that obviously we don't know the results. The study is still accruing. So I think all these studies, hopefully we'll see some of the data in the next 1 to 2 years, and I think depending on the results, may further kind of give us a further choice or information about various these combination regimens if one is better than the other. So I'm going to quickly, I thought maybe next 10 slides or so on relapsed refractory CLL, just to kind of, because I really focused on frontline CLL, but I thought I will highlight some important studies in the relapsed refractory CLL before we close up. and do the question answer session. So in the remaining 10 slides, just in the relapsed refractory CLL, because where you may be treating maybe most of your patients with ibrutinib, where a patient had a prior BR and then you're progressing and you're going to use ibrutinib. So the first study was by John Bird, which led to the approval of ibrutinib, was ibrutinib versus ofatumumab in the relapsed refractory setting. Here you have to remember one thing, that the median number of prior therapies for the ibrutinib arm was 3 therapies. So these were heavily pretreated patients who had 3 cycles of 3 regimens of chemotherapy before they came to get ibrutinib. So this is a study which was started enrolling in 2010, 2011. And certainly you see improved PFS with ibrutinib. Now, more recently, a final analysis of this study was published. So this is the 65-month follow-up, so 5.5 years. And what you see here is that ibrutinib is certainly superior to ofatumumab, but really no concern about using ofatumumab. No one uses ofatumumab as a single agent. But I think it was good to see that in such a relapsed refractory population, ibrutinib was leading to a 3.5 progression-free survival on an average for our patients. And another interesting observation, which has now been known with other studies as well, that remarkably, deletion 11q patients, which used to be high-risk patients for FCR in a way, were actually doing the best. And this is the long-term follow-up data. As you can kind of see, the top curve here is 11q. The middle curve is patients who have no 11q or 17p, and the bottom curve is 17p. And one last study I wanted to highlight, because I think when we talk about MRD, it's a very important study, is the Morano study, which is a relapsed refractory CLL getting ven rituximab. And this, I think, is a very landmark study in my opinion, because what the investigators did was comparing ven-R with the standard of care bendamustine rituximab. So very appropriate comparison for relapsed refractory patients. And clearly, and I think there is no question about the study, you see a wide separation of the PFS curves in favor of venetoclax rituximab compared to bendamustine rituximab. This study also very nicely brought up this concept that MRD really matters. I mean, certainly we knew MRD matters with chemotherapy, but with this venetoclax rituximab, MRD matters that at the end of treatment, if you're MRD negative in the blood, you do well, less chance of progression. If you're MRD positive, higher chance of progression. So again, makes sense, but it was nice to see this in an actual data set. And importantly, the study also showed overall survival benefit for these patients. So it's not just the PFS benefit, you're seeing an OS benefit. In my opinion, I think this study clearly establishes venetoclax rituximab as a standard of therapy for relapsed refractory CLL over bendamustine rituximab. You have a PFS advantage and you have an OS advantage. Just want to spend, I think there may be some questions about MRD, so I thought I will add a couple of slides on MRD. Just what minimal, or some people call it residual disease, I think is quite obvious for us as clinicians to mean that MRD positive means disease is present. But many times when you're explaining to the patient that you are MRD negative, what they may not understand is that the MRD negative does not mean disease is absent. It just means you cannot detect the disease. And therefore, the new terminology in the CLL field, at least, is using this term called undetectable MRD, basically saying that we cannot detect MRD doesn't mean you are MRD negative, which is UMRD4, where the 4 represents the sensitivity of the assay use. So many of the studies you will see will say UMRD4 or UMRD6, and again, that based on the assay sensitivity you're using. And again, this is kind of nicely shown in this figure, which again, the depth of remission matters where, and again, you may be MRD negative by flow, but still have disease left, certainly, which can relapse later. How do I use MRD? I think we certainly use it in the context of clinical trial, and sometimes it's in the blood or the marrow or both. I use MRD for venetoclax-based therapy, and where the timing of treatment discontinuation is a question. And peripheral blood, I think, in my opinion, should suffice for venetoclax-based strategy. And certainly FCR, again, we're not really using much of FCR these days per se, but again, if you were to use, that could predict long-term progression-free survival. So my second to last slide. So I think, and this is kind of a conclusion slide in a way, but there are some unanswered questions in the field. I hope I showed you where the field is moving, what trials we are looking for. I think what field is moving towards is a frontline therapy, which is time-limited target therapy combination. And I think we have a variety of BCL2, which is only venetoclax right now, practically, combinations. We have venetoclax plus CD20 antibody, we have venetoclax plus ibrutinib, we have venetoclax plus acalabrutinib being pursued, and we have triplets. And I showed you some of the many studies which are happening with triplets. So I think it remains to be seen which is the right strategy, which is the right combination, which is the right BTK inhibitor, whether you can do with rituximab or you really need obinutuzumab. I think some of these answers we may get by these randomized studies in the frontline setting, which are happening. We truly don't know the ideal treatment duration. I mean, the study we did with ibrutinib plus venetoclax is for 2 years, but other centers are doing 1 year of strategy. Some people are doing MRD-based strategy. You get to MRD negative, and then you stop after X amount of time after being MRD negative. So truly that is an answer right now. And though we didn't talk about it, there are several other agents in development right now, so reversible BTK, and there are other things going on in the field as well. And certainly CAR T cell strategy, I didn't really discuss that, but happy to take any questions on that. And Dr. Agarwal alluded to a patient case where he benefited from CAR T. So certainly a very valid strategy for relapsed refractory CLL as well as Richter's transformation. So the topic Dr. Agarwal gave me, this is my last slide, was future of CLL therapy is MRD-guided, finite, and combination oral therapy. And to be honest with you, when he told me this, I didn't really pay much attention, and I said, sure, fine. When I was making my slides last night, I was like, oh man, this is actually a bit of a loaded question here. So I think what I do think is that I think the future of CLL therapy is probably finite. I think no one wants lifelong ibrutinib, no one wants lifelong acalabrutinib. At least I'm talking from the perspective of the United States. Again, in Indian context, maybe slightly different, but I think that where we are moving is a finite therapy. Certainly, we are moving towards combination therapy. I didn't select oral here because I don't know whether it's possible that venetoclax plus a BTK inhibitor may do the job. Maybe venetoclax plus obinutuzumab may be a standard, or maybe there is some other IV combination you need in the mix. So that's something I think remains unanswered. And I think MRD guided question is also, certainly we use it. But if you look at the CLL14, if you look at the Morano, MRD was really measured, but therapy was not guided by MRD. You stop therapy at 1 or 2 years, irrespective of the MRD, and you follow the patients along. So whether MRD guided will be there, I think I'm not sure. So I think that's 4 parts to this kind of a loaded topic. I would say, certainly in my opinion, it will be a finite and it will be a combination targeted therapy. I think whether it's MRD guided or oral only therapy, that remains to be seen. So with this, I would like to conclude. Thank you for listening. This is my email address, my Twitter, and also my direct phone number to my desk at MD Anderson. You're obviously more than welcome to reach out to me in any fashion for questions, discussion. So thank you for listening, and I hope you enjoyed the talk.
Thank you so much. It was great. And we have certain questions which have been invited from our members throughout last 2-3 months. So we're going to first take up those questions to you, and then we will also take up some questions which have come up just now. So
should I stop sharing my screen, I guess?
Yeah, yes. So I will share my screen to put those questions up. Right, so we begin with the questions. First is the case scenario of the management of a young, fit CLL patient. And there are 4 questions. I must tell you, Dr. Jain, that many of these things you have answered, but maybe at the cost of repeating them, it may benefit the trainees. So, use of FCR is to be restricted only to a young, fit IGHV mutated CLL with deletion 13q. Your comments on this, followed by, is it essential to give 6 cycles of FCR, or you are guided by MRD? The third part is FCR outdated as against FCRI, or today you told us about FCGI, and what are the challenges you face while giving this FCR type of therapies?
Yeah, so certainly, I mean, I think as probably I showed you in the talk, I think IGH mutated patients certainly is the one we are restricting the chemoimmunotherapy. I'm not sure if you really need to restrict to deletion 13q. I think patients we have with trisomy 12, other fish abnormality, certainly, without deletion 17p, that should not get chemotherapy. But as long as you're IGH mutated, I think you do well with the chemoimmunotherapy, at least in the FCR series. So I personally would not restrict it if you're going to use FCR and someone has trisomy 12 and IGH mutated. I think that's fair to use. 6 cycles of FCR. So certainly, at our center we have not used FCR, I would say, since 2016 now. So because our strategy is to use IFCG regimen, which I kind of discussed that with you. So we are not actually using FCR anymore. Nonetheless, if you want to give FCR, we have reported a study previously where if you do 3 cycles of FCR, you do an MRD assessment. If the patient is MRD negative, there was no benefit of getting 3 additional cycles of FCR. So potentially, if you really are, certainly want to use FCR, you can do 3 cycles, see if you can get an MRD assessment on the patient, and then be able to stop therapy. I personally would not give 6 cycles of FCR. I mean, I think in today's world, I think, you are kind of, there are other better options available. Is FCR outdated against FCRI? So I think it's, again, I showed you the IFCR study. Again, it was using 6 cycles of chemotherapy and adding ibrutinib to it. The regimen we have with IFCG or FCGI to say in this context, we only use 3 cycles of chemotherapy, and the results I showed you, I think, looks quite promising to us with 3 cycles of less chemotherapy. So that's something we are favoring to use for at least for our patients here. And hopefully, once we get the manuscript out, it will be, you can see it in more clarity, the details about the study. And so that's what I would say. Again, we are not really using FCR, but certainly with FCR, the risk of infection, prolonged myelosuppression for some patients, potential risk for MDS AML, those are certainly the issues with standard 6 cycles FCR.
Thank you, Dr. Next question is about CLL-10 trial. CLL-10 trial showed comparable overall survival between FCR and BR with better safety with BR. Given this data, do you consider BR in place of FCR in a young fit person?
Yeah, I mean, I think so. In my mind, so certainly I think if your benchmark is OS, you say, okay, I'm not going to change my CLL practice unless I see an OS benefit between the 2 regimens. Then for that matter, I think, practically most of the regimens have not shown an OS benefit. And in that case, I think even chlorambucil obinutuzumab, you can say, hey, if you compare that with Ven-G, venetoclax obinutuzumab, OS is the same. If you look at chlorambucil obinutuzumab with ibrutinib obinutuzumab, which was the Illuminate study, I didn't show that in the interest of time, OS is the same. So with that argument, certainly I think chlorambucil obinutuzumab would be fine. So I think, with that argument in mind, I think you can certainly say I'm going to use BR in place of FCR. I think if progression-free survival is a consideration, then certainly FCR was better than BR. I would say that in my mind, the only reason for using chemoimmunotherapy in this world or right now would be that potential PFS advantage at 10 plus years of mutated patients with FCR, that tail to the curve. We don't see that with BR, So that's the only reason in my mind. So if you're giving a chemoimmunotherapy, you are hoping that patient will get 6 cycles or maybe 3 cycles of FCR and will be progression-free 10 plus years, possibly cured in half of the patients. And that's really the only reason to use chemoimmunotherapy. Short of that, I would not consider it. I mean, I would really consider targeted therapies for these patients. Why to subject them to the potential risk of chemoimmunotherapy?
Thank you. The next question is about E1912, IR versus FCR frontline. This was the study that showed significant prolongation of both PFS and OS with IR as against FCR. So do you consider this data as practice changing in young fit person of CLL in favor of IR?
Yeah, so, as I showed, so certainly I think for unmutated IGVH, there is no question in my mind. I think this study has changed the practice, at least in the United States, for a lot of physicians, and I'm sure elsewhere as well. where we have access to these drugs, where you would say that why, and for unmutated patients, certainly you see a improved PFS of ibrutinib rituximab, and I think this study made a real point that FCR should not be used for unmutated patients. For mutated patients, the curves are overlapping. We also have the data with 10 plus years follow-up for mutated patients with this so-called cure fraction of 50%. So if you believe in that study, if you believe in a cure fraction of 50%, then I think FCR is reasonable for young, fit, mutated patients. But if you say, hey, I really don't want to subject my patients to FCR, and yes, there is a cure fraction, but maybe there will be some kind of a cure fraction with ibrutinib eventually, 10 years on the line. And I think then ibrutinib is absolutely fine to use in this patient population. So when I'm talking to the patient, I'm not telling them that for young fit patients, IGH mutated, FCR is the only option and that's it. I give them the option. I said, you can do FCR or IFCG on the trial, or certainly you have the option to do target therapy alone. There are these risk and benefit, and kind of let patient make that decision, because it's quite possible we may see some durable long-term remission with target therapies as well.
We move on to the second situation, and that is elderly CLL. So, do all need 420 mg of ibrutinib? Can the dose of ibrutinib be lowered? Does that reduce toxicity? Second part is, what percentage of patients really continue full dose of ibrutinib for many years? Third part is there a place for intermittent ibrutinib therapy? And the last part is, with ACAD ibrutinib around, are the days of ibrutinib numbered?
Yeah, so all very good questions. So, I think the dose of ibrutinib has been under some discussion. There has been studies, retrospective studies, I should say, looking at lower doses of ibrutinib, where the lower dose of ibrutinib did equally well in small number of patients. We have also seen that the dose reduction of ibrutinib, where the dose is lowered for some toxicity, the PFS is generally the same. Certainly the toxicity question, I think if you reduce the dose of ibrutinib, many patients will have less toxicity, so that's only we do it in our practice. We had also done some studies looking at the PK analysis of lower doses of ibrutinib, where actually lower doses of ibrutinib were equally good. But I think outside of a clinical trial setting, and I don't know if anyone is looking at lower doses of ibrutinib in a clinical trial setting, we were trying to look at that, but last year, but that study was not funded. I think I would say that's to stick with the 420 milligram of ibrutinib, which is the standard approved dose. I would say in my practice, maybe 20 to 30% of the patients have decreased the dose of ibrutinib for some reason. Remaining 70% or so are on full doses of ibrutinib. But I think the threshold is low. If you're a patient who is on 3 years ibrutinib, they're having some ongoing toxicity, some rashes, some bruises, some joint pains, I think certainly I consider decreasing the dose for those patients. Intermittent therapy is an interesting question. This has not been studied yet, but is being studied now, where you may give 2 years of ibrutinib, 2 years of acalabrutinib, or zanubrutinib for that matter, and then you stop the therapy, irrespective of the response, with the goal that when the patient progresses, you will retreat them with the same BTK inhibitor. So those studies are happening now, so I think it'll be some time before we really know kind of the results of those studies. But certainly I would say there are patients in my practice, and I'm sure others have as well, where patients have stopped the BTK inhibitor for some reason, some AFib, some infection, whatever, and then you don't resume them, and then months and actually 1 or 2 years or a few years may go by before they need therapy. So certainly I think there's a case for that, but that is being studied in clinical trial. The last question is certainly an interesting question. I think, acalabrutinib in a cross-trial comparison does appear to have more patients are staying on acalabrutinib than ibrutinib. It has less issues with atrial fibrillation, appears to have. So it's tolerated a bit better. And there are studies where patients who are intolerant to ibrutinib, they were switched to acalabrutinib, and actually they did great, a majority of them. So there is a head-to-head trial of acalabrutinib versus ibrutinib in relapsed refractory CLL, which we are all waiting for results. There's also a head-to-head trial of zanubrutinib versus ibrutinib head-to-head in relapsed refractory CLL. So I think there are 2 head-to-head trials. kind of accruing and accrued, and we're waiting for the results. I think at the end of the day, the results of those trials will really kind of change the practice, I think, depending on what we see there. But it's possible, I think, and I'm using more and more acalabrutinib in my practice based on my experience with the patients so far.
Thank you. With rituximab has no advantage over ibrutinib. How do you select between remaining combinations? That is, ibru with obinu or ibru with venetoclax?
Yeah, so ibru with obinu. Oh, okay. So I never use ibrutinib with obinutuzumab because, again, there is no randomized data to support that. I mean, there is randomized data comparing chlorambucil, but there is no head-to-head data of ibrutinib versus ibrutinib obinutuzumab. So yes, rituximab doesn't work with ibrutinib or has no advantage. It's possible that obinutuzumab with ibrutinib has an advantage, but that's not proven yet. And certainly there is data with acala plus obinutuzumab, right? The ELEVATE-TN study I showed you, the 6% PFS difference. But again, that's, in my opinion, in my mind, that's not a substantial difference to subject a patient to receive obinutuzumab with all the side effects and the cost and the infusion reaction. So I personally don't do it with obinutuzumab. Now, ibrutinib venetoclax, again, in the United States, is not yet approved. It's only really being done as part of clinical trial. I have few patients, young patients with deletion 17p, who have opted for ibrutinib venetoclax outside of a clinical trial setting because they really wanted to get MRD negative and they really wanted a depth of remission. So we are using them, in those some patients, I would say. So outside of a clinical trial, that's really not an option at this time for me. So I think the option to use right now would be venetoclax or venetuzumab in the frontline setting. If you're looking for a time-limited option, that's the only time-limited option we have right now in the US outside of a clinical trial setting. Ibrutinib plus venetoclax may become FDA approved late in the next, who knows, couple of years, depending on the results of the randomized studies. But until those are available, I think that still we will use it as part of a clinical trial only.
About ELEVATE-TN trial. In this phase 3 trial, there were 3 arms: acalabrutinib, acal with obinu, and chlorambucil with obinu. Based on this study, will you recommend acalabrutinib monotherapy? You have mentioned or you have discussed this. You can just answer this.
Yeah. So I mean, I only use acalabrutinib monotherapy. I do not combine it with obinutuzumab.
Fair. Yeah. We move on to the management of high-risk patients and relapsed patients. So CLL 14 trial, venetoclax with obinu versus chlorambucil plus obinu. Phase 3 trial in upfront patients of CLL. What are your views on CLL 14 trial results where venetoclax failed to show benefit in TP53 mutated subgroup?
Yeah, so as I mentioned, I mean, I think I would just clarify the statement that venetoclax did not fail to show compared to chlorambucil. I mean, for TP53 mutated, it is still better than chlorambucil or obinutuzumab, venetoclax or obinutuzumab. But certainly the results were not as great as we have wanted because we see progression of patients after they're stopping the therapy. So for this group of patients, as I said, I think I'm now favoring a BTK inhibitor because of the fact that we are not seeing a durable progression-free survival on the CLL14 for this specific group of patients. So that's something, has changed for the P53 mutated group of patients based on the results of the CLL14 trial update, which was at ASH.
Thank you. Is finite therapy possible for a high-risk CLL? And these various groups have been put down there. In a young, fit person with high-risk CLL, will you consider all the medical treatments as a bridge to allotransplant?
Yeah, so, in my opinion, I think in these days, the only high risk would be considered as the first two, deletion 17p and P53 mutated. I think unmutated is not really a high risk CLL anymore with the ibrutinib venetoclax. And complex karyotype, I think it's kind of an evolving field where if you look at the RESONATE studies, actually the long-term follow-up of the RESONATE studies, complex karyotype is not a negative predictor anymore. They just reported with the CLL14, complex karyotype is not predictive anymore. in the Alliance study, the older patient study with bendamustine rituximab, ibrutinib versus ibrutinib rituximab, complex karyotype did not predict. So I think in my mind, complex karyotype has kind of losing the kind of maybe the importance a few years ago we were really thinking about. So to me, the only high risk is the first two, del17p and p53 mutated. And I think for these group of patients, certainly a BTK inhibitor, I think, would be a preferred approach rather than a venetoclax-based approach, because I think the time-limited therapy with venetoclax or venetuzumab or venetoclax rituximab may not be an answer. Whether venetoclax ibrutinib will be an answer, I think that remains to be seen. It's too early to say. And I think the question of transplant, I think certainly a young fit patient, we generally transplant when patient has failed at least one targeted therapy, that they have deletion 17p53 mutated, they have failed ibrutinib, you're putting them on venetoclax, and then that this patient may not have a long-lasting remission of venetoclax, so then you really start thinking about allotransplant for these patients. Again, that's a discussion because many patients do not want to pursue allotransplant for the side effects it has, and at least in the United States, with the CAR T kind of becoming as clinical trial available, many patients kind of want to take their chances where they say, hey, let me just put on venetoclax. If I relapse, I may go to CAR T, and then we'll see if we go to transplant or not. So I think it's an evolving field. Very few patients, I would say, in the US are getting allotransplant for CLL these days.
MRD, you discussed a lot, but do you use MRD as a clinical tool? You mentioned no. And which technique is good enough? Flow, PCR, NGS, NGF, and is from peripheral blood as good as bone marrow?
Yeah, so at our center, we use MRD by flow cytometry with a sensitivity of 10 to the power minus 4. So that's the standard, and most studies, most clinical trials report that, and that's what we do as well. From the peripheral blood versus the bone marrow, I think there is certainly a slightly, maybe a 10% higher rate of detection if you do bone marrow and peripheral blood at the same time. So if you look at the venetoclax-based studies, the concordance between the two, blood and the marrow, is 90%. So I think that has led to this argument, which I think is a reasonable argument because no one wants to do bone marrows, is that the peripheral blood may not be sufficient, and really we don't need a bone marrow for these patients. There are also these assays which are a higher sensitivity assay, NGS-based assays, which can go up to 10 to the power minus 6. And I think those in the peripheral blood are very, very potent in terms of detecting the level of disease. So I do believe that I think bone marrow MRD will probably go away in the field of CLL. We'll all be using peripheral blood MRD. And it's quite possible that if these NGS-based assays become more commercially available widely with a sensitivity of 10 to the power minus 6 to say, I think they may become an important, easy and important thing to use in the peripheral blood. But there's very few data right now with NGS in peripheral blood for patients with CLL. But I think eventually the data will emerge in the next 1 to 2 years for that.
Thank you. Some miscellaneous conditions. Any suggestions regarding managing CLL in COVID era?
Yeah, I mean, I think we all are learning. I mean, I would say nothing. I mean, I'm no specialist in COVID-19, but certainly we have patients where I would say back in March and April, the thought was if a patient is on ibrutinib, then if they get COVID-19, I was stopping their ibrutinib because just we didn't know. And there was thing of obviously ibrutinib causes AFib. I had a patient with severe AFib and got COVID, and it was kind of a mess. So now, obviously, as you guys obviously well know, ibrutinib, acalabrutinib, all these drugs are being studied in phase 3 trials for COVID-19 in general all across the world. So I think these days, if I have a patient with ibrutinib who gets COVID-19, I'm not stopping their therapy. I say keep taking the ibrutinib. If they are in home isolation or whatever, keep taking the ibrutinib, hoping that will prevent some severe CRS. So certainly on a more general note, I think if we have a lot of COVID in your area, in your city, then trying to have regimens where patients doesn't have to come to the hospital that often, avoiding IV infusions, frequent lab checks is important. And in that regard, it has been argued that a BTK inhibitor combination may be better because you don't have that many visits to the hospital. But that's kind of an evolving kind of a field. I don't think there are any strict guidelines to that. in our center, we have really practiced as usual. A month ago, we had a lot of COVID in Houston. There was a big surge. But now it's kind of coming down. So nothing I would say remarkable, but the only thing will be, yes, certainly ibrutinib and acalabrutinib, and now some CRS-related activity for COVID-19.
Thank you. Regarding this epidemiology, which I mentioned in the beginning, the disease being rare in the eastern part of the world, more common in the western part, is it due to genetic factors, environmental factors, both? And is the disease biology different? Any data on all this?
Yeah, so I mean, I think there is not really substantial good data, and I have not really studied this topic that closely. But what we know is that I think the genetic factors are a major player, because the people who have moved from India or maybe China or other countries to the US, their risk of CLL still remains on the low side. So I think that has led to the argument that the genetic factors are really more important than the environmental factors for these patients. And there have been studies from India. I think there have been several studies, some recent studies as well, looking at different biology, looking at their IgVH, FISH, all those other things. There are studies looking at the IgVH subset on these patient population, and there are some differences between the West and the East to say, I think, but there's no large scale, as far as I know, population-based study, because if you have a center, which is a large center in India, which gets referral for patients who are sick, and if you look at their patient population, they will have more 17p, because those are the patients you're kind of in your practice. To really know the incidence, you have to do a more population-based study, which I don't think I have seen that. Maybe there is something, I don't know. But yeah, I mean, certainly I think it's well established that the risk is low in India, in Japan, in China, as compared to what's in the US.
In the US, the mutated cases is around 35-40%?
Correct.
Okay. Prevention of infection. What is the policy? Pneumococcal vaccine, antimicrobials, IV gamma globulin, and any prophylaxis with the BTK inhibitors?
Yeah, so we typically for CLL patients, the prevention of infection will be just the vaccination. So flu vaccine each year, a pneumococcal vaccine every 5 years. Maybe there will be a COVID vaccine soon, so that maybe we should be giving to them. Now, antimicrobial prophylaxis, if they're not on treatment, I don't give any prophylaxis to them. If they have received some treatment, certainly HSV prophylaxis with valacyclovir or acyclovir is something which is standard. Now, I would say that we have adapted that from the FCR era, where with chemotherapy, we were doing Valtrex or valacyclovir prophylaxis for HSV. We have used the same strategy, I would say, for our patients with ibrutinib and venetoclax and all these studies. Whether that's really essential, I'm not sure. We don't do antifungal prophylaxis. There is some concept of using a PJP prophylaxis with Bactrim. In our center, we have not used it. And I would say that I know Ohio State also hasn't used it, and Dana-Farber hasn't used it. There is some evidence that with ibrutinib, there's an increased risk of PJP, but we really haven't seen it in our practice. So without a PJP prophylaxis. So we don't use PJP prophylaxis. So the only thing I use with ibrutinib is generally a valacyclovir or acyclovir prophylaxis for these patients. IVIG, in our practice, or at least in my practice, I only use if the IgG is less than 500, and the patient has an evidence of a severe infection requiring a hospitalization at least once a year, or if they have a severe ongoing infections which are really affecting severely quality of life. But if they just have a IgG of 400 and they have 2 sinus infection in a year or something like that, I don't start them on IVIG for that.
Right. Incidental diagnosis of CLL, patient asymptomatic and young, any intervention is likely to help him in the long term?
Well, so no CLL, so there are these studies of early intervention studies. So there was a CLL-12 study which was reported last year, I believe, where patients in this situation were given ibrutinib versus placebo. And there were actually side effects from ibrutinib for this early intervention study, and many patients stopped ibrutinib. And so I do not think any intervention has been proved to be successful. Now, currently, there are studies looking at venetoclax-based regimen as an early intervention strategy. Like you're diagnosed with CLL, you have some high risk feature, you give them venetoclax or obinutuzumab like right away. You don't wait for their disease progression. And those studies are happening right now. And I think when eventually they get reported, it may be some years. I think that may hopefully change the practice. But right now, outside of a clinical trial, standard of care, even if you're deletion 17p, would be just watch and wait as kind of we do right now.
Right. Bone marrow test and imaging, are all these required at the initial diagnosis of a CLL?
No, so we don't do bone marrows, we don't do PET scan, we don't do CT scan for newly diagnosed CLL. I would do them only if they need treatment. So if they're coming, they have a rise to 0 or 1 disease, something like that, some palpable lymph nodes, otherwise feel fine. I really have no reason to think that they need treatment. We just do a peripheral blood flow cytometry. We also send the peripheral blood for the FISH and the IgHV status and a P53 status, but we do not do CT scans, we do not do bone marrow or a PET scan. And as I said, I will only do them if I'm starting a patient on therapy, before starting a therapy, I mean. And I don't really use CLL IPI in clinical practice. This is more for clinical trial, but nothing in clinical practice.
Is there any place left for PI3K inhibitors, or it is getting outdated?
So, I think a PI3 kinase inhibitor right now we have 2 approved, idelalisib and duvelisib. I have not used them in recent time, but I think they are certainly could be considered if someone has failed ibrutinib, someone has failed venetoclax. You're looking for a 3rd line option or maybe a 4th line option if the patient happened to have FCR or BR as a 1st line. Yes, what else you're going to do for that patient? Yeah, use PI3 kinase inhibitor. Now, I would say that there are some other PI3 kinase inhibitors, namely one drug called umbralisib, which is in a phase 3 studies, both for frontline and relapse CLL. It will likely get approved in the US because I believe the press release was that it's a positive study. And that has appears to have less toxicities, better tolerated, it's a pill. So that may become approved agent. Umbralisib is being studied for follicular lymphoma and other diseases as well. So maybe if that comes along, maybe that will become a preferred PI3 kinase inhibitor, and maybe could be used in early lines of therapy. Again, that's something we truly don't know at this time.
Right. This business of second malignancy, CLL is supposed to be prone to develop second malignancy. What are the common sites, and what do you do in your routine practice to screen for them?
Yeah, so I would say skin cancer is the most common thing, at least we see in the United States for these patients, but they could have other solid tumor malignancy, lung cancer, colon cancer, whatnot. I tell them, I tell them to follow the recommended guidelines in the United States for general population, because most patients do not follow that. Obviously in India they don't follow that. In the US also they don't follow that. So what are the guidelines? Is colonoscopy every 5 years, mammogram, pap smear, prostate. I just tell them that be up to date with the screening guidelines which have been reported for general population. And as long as they're up to date with them, I'm okay. I'm not proactively doing more than what has been recommended by the United States Preventative Task Force.
Right. Digital transformation, is there any way to reduce its risk? Are there any determinants when to suspect, how to treat, and is CAR-T therapy the ultimate?
Yeah, so that's actually a talk in itself, but I think just very briefly, Richter's transformation, I think certainly it appears that when we're using chemotherapy more and more, there was certainly a risk. Now, I think as far as we know, the novel therapies, ibrutinib, venetoclax, they do not induce Richter's transformation, unlike the case with FCR, where there was a selection of P53 clone with FCR and whatnot. So maybe eventually we'll see less of Richter's transformation because we are going to use less and less of chemotherapy. In terms of the determinants, I think some of the determinants are the same. Deletion 17p, P53 mutation, complex karyotype, those are more likely to get Richter's transformation. When to suspect, certainly if a patient has elevated enlarging lymph nodes, fever, high LDH, I think that's something you worry about Richter's transformation. I generally do a PET on those patients, and then it is very important to biopsy the hottest lymph node. because if you just biopsy a lymph node which is easily accessible in the neck or axilla, and their Richter's is actually in the portal area, you will just say, oh, patient has CLL, but actually no, patient had a Richter's in his abdomen and you just missed it. So it's really important to do a PET scan and make sure you biopsy the hottest area to confirm Richter's. And then, I think there are strategies being used now. There is a regimens with venetoclax plus chemotherapy being pursued. We have done some work with checkpoint blockade with Richter's transformation with nivolumab and ibrutinib. And certainly CAR-T therapies are looking promising. I would say it's still tough. I have had patients, and I'm sure others have patients as well, some of my colleagues, where patients with Richter's transformation, you really believe, oh yeah, CAR-T, way to go to CAR-T, and 30 days later, no response. So, I think it's an evolving field, but certainly there is a hope that many patients will respond to CAR-T, and the CAR-Ts are becoming, better and better as well. So, so I think we are now having several trials. I'm a part of some of these CAR-T effort as well, both for CLL and ALL, which is the other disease subtype I kind of work on. So I think that I'm really excited about CAR-T as a strategy for refractory CLL, Richter's, also in the context of relapsed refractory adult ALL. I think eventually we'll be there with the CAR-T strategy.
Right. Will you take some questions which have come up?
Sure. Yeah, that's fine.
Right. So, ibrutinib and aspergillosis, is there an increased risk?
So we haven't seen, in our center, we recently actually just published a paper, I think it's in Leukemia Lymphoma Journal, where we looked at over 800 patients with ibrutinib we have treated at our center, and the risk of invasive fungal infection was very low. I forgot the number, but it was like 1 or 2%, something like that. And this is despite that we do not do prophylaxis. So I think some of the studies have shown them. Some of the studies were using concomitantly steroids for these patients with ibrutinib. But if you're just using ibrutinib, or for that matter, acalabrutinib for your CLL, again, it will be rare to have it, but certainly could happen. But I don't think there is a need to prophylax them with voriconazole or posaconazole or some kind of fungal medication.
Thanks. So some question related to infections due to bendamustine. Why does that happen?
To be very honest with you, I have never really prescribed bendamustine in my life. But certainly, I think it's, if you're asking specifically for the CLL10 study, where the data I show where there were more infections in the younger patients with bendamustine versus fludarabine FCR, I think certainly bendamustine can cause prolonged myelosuppression. There's a T cell suppression, which is true with fludarabine as well. I suspect that's what leads to it with chemotherapy, but I'm no expert in bendamustine to kind of say.
We just talked about this lymphocytopenia persisting for years after bendamustine. Yeah. Right. One question is, if you're treating with novel agents, do you have to do FISH studies and mutation status?
Yeah, so that's a good point. So you may argue that if ibrutinib, venetoclax, they work equally across IgG status, what's the point of doing this? Because it doesn't really matter anymore, if they have it or not, because you're going to use. And I think there is some validity to that concept. I think if you have limited resources, you are going to use a targeted therapy for your patient. You do not want to check the IgG status because of the financial issues. I think it's fair. However, I think what still matters is FISH 17p. What still matters, you have access to it to do a p53 sequencing. So that, I think those two, if you have limited resources, if you want to do kind of two tests, don't worry about beta-2M, don't worry about ZAV70C38, those things really don't maybe matter in a practical sense. Do a FISH test for 17p and do a p53 sequencing. I think those are the most important ones. You can potentially skip the rest of them if you want.
So there is a question that based on TP53 mutation and IgVH status, can you have two groups of patients whom you will give ibrutinib or venetoclax-based therapy?
So, I think in the frontline setting, I would say that, for deletion 17p, p53 mutated patients, certainly I think a BTK inhibitor would be my preference at this time, because of what we are seeing with the CLL14, that the patient with 17p seem to be kind of relapsing. All other patients in the frontline setting, I think a BTK inhibitor and a venetoclax ibrutinib are equally good therapies. And I think this is a discussion I have with the patients, that one therapy is kind of easier to get in. You just prescribe ibrutinib or acalabrutinib, they just kind of take it, no practical risk of tumor lysis, no monitoring really that closely. But it's a lifelong therapy versus a 1-year therapy with Ven-G. I would say more patients choose Ven-G because they like a time-limited therapy. They feel that they are done, especially in the context of India, maybe when venetoclax gets approved or available, depending on the price and whatnot, maybe a more appealing option in that sense, because then you are done in 1-year therapy. So I think for most patients, I think venetoclax or obinutuzumab is a great therapy, and I use it quite often, except that del17p p53 group at this time.
So if after 1 year and 2 year of venetoclax-based therapy, if your MRD remains positive, you continue venetoclax or you're stopping it?
Yeah, so I think the standard recommendation would be to stop, because the trial stopped everyone. They didn't really care about the MRD. I think the patients who are going on these studies are really going in the bent of mind, I want to be MRD negative, right? I mean, and after 2 years or 1 year, if you say, oh, your MRD is 0.05, they want to continue and they want to get to that MRD zero state. So in my practice, I would continue. Again, that's not a evidence-bound recommendation. We don't know truly what to do for those patients. Someone could say, hey, why don't you add rituximab 6 months for that? And maybe that will get to MRD. It's possible. We just don't know. So, but in my practice, I think they're MRD positive. I discuss with them the pros and cons, that, hey, we can stop it and you may just do fine for, who knows, quite a while, or we keep going and see how things go. So it's not really a clear-cut answer, but in my practice, I would continue until we know more.
We talked about FCR and allied therapy making MRD negativity after 3 cycles and stopping. So the question is, if the MRD remains positive, then you continue FCR 6 cycle or you give different regimen?
Yeah, I mean, I think no one knows the answer to that. I mean, if you're going FCR, you give 3 cycles of FCR, patient is MRD negative, okay, I think you can safely stop it. Patient is MRD positive, do I still need to give 3 additional cycles of FCR? I think maybe, it's quite possible if you have access to new drugs, if you have access to ibrutinib, I personally may consider just stopping it at that time, watch the MRD. They may do well for the next couple of years. And once their MRD recurs, the disease progresses, then you could potentially intervene with ibrutinib or acalabrutinib or something like that. Or, I mean, you say, hey, if the patient tolerated it fine, 3 cycles, no infection issues, nothing, I really want to give 3 additional cycles for them to become MRD negative. I think that's a reasonable approach. But I think we have at least moved away from 6 cycles of chemotherapy. So I would favor probably 3 cycles and maybe calling it quits.
Right. There's a question like, in acute leukemia, are there fixed time points when you do the MRD in CLL?
Yeah, I mean, I think so. The MRD in CLL practically only matters if you're using a venetoclax-based regimen, right? Or chemotherapy. With ibrutinib, there's no MRD needed to be checked. Acalabrutinib, same question. So if you're using venetoclax, then the MRD question comes along. In that case, I would check in a peripheral blood. If you are doing a 1-year frontline therapy, I may do it at 9 months mark, just to kind of get a sense of trajectory where it's at 9 months, and then I do a 12-month, just to kind of see if it's going down, going up, what's happening. And the same thing could be true for relapsed refractory setting. If you're using a 2-year of venetoclax rituximab, you can do at 18 months. I mean, you can do more frequently if you want, but to kind of get a sense of the patients, but at least do it at the end of treatment, so end of when you're planning to stop the venetoclax. And again, in the chemotherapy era, the FCR era, the standard was to do approximately 2 months after the finishing of the chemotherapy. So that's with the chemoimmunotherapy era, that was what was being used.
Right. Question related to CAR T therapy, like bone marrow transplant, are there restrictions with respect to age, comorbidities, performance status, etc.?
Yeah, I mean, I think certainly there are restrictions, right, to CAR T. certainly in the US, CAR T for DLBCL, mantle cell now, it's approved, right? So it's widely available. For CLL, it's not yet approved. But yeah, in general, because you have to give fludarabine, cyclophosphamide lymphodepletion, you want to make sure the patient is a fit, they have a good kidney function. I would say that there are patients in their 70s who have been receiving CAR T, and I think so. The criteria I would say a bit less strict as you would maybe consider for CAR T, as you would consider for a stem cell transplant, where you really want a healthy patient. I think here, especially when the CAR T is approved, if you have a relapsed refractory DLBCL or something like that, you really, even with somewhat of a poor performance status, you could potentially go into the CAR T. So yes, I think there is a basic minimum requirement, but certainly, if you have a 95-year-old or 90-year-old, you want to do CAR T, probably not the best idea. But I think 75, 80, I think if they're in good PS, yeah, sure, why not? So some of the general criteria I would say to consider for CAR T as a physically fit patient in a way.
Right. Another question about CAR T: is it the final treatment, or it is only a bridge to transplant?
So I think we don't. I think so. This is a CAR T. CAR T for CLL, very limited information right now. Right, very few data have been published. We really don't know if they need transplant at the back end or not. This discussion so for the CLL, we don't know. For ALL, I think it's an evolving field. If you're talking about the ALL, I would say yes. I think we should bridge them to transplant in adult ALL. For pediatric ALL, maybe different. But for CLL, in adult CLL, or CLL is adult, I guess, but in CLL, we truly don't know. I personally probably would just do CAR T as a standalone therapy. That's what we have done for our patients, not going to a transplant at the back end. But very limited data really in that regard.
Question that you give rituximab maintenance for follicular lymphoma, mantle cell lymphoma. Are there trials in chronic lymphocytic leukemia?
So there have been trials with the maintenance strategy with chronic lymphocytic leukemia. They showed that if you do FCR and then some kind of a maintenance thereafter, with rituximab, your PFS is prolonged, OS is still the same. There were studies done. I think these have now fallen out of favor. They were done actually several years ago. I think 5-6 years ago, they were reported, I believe, a couple of studies. But they haven't really caught on because, to be honest with you, no one is using FCR. With ibrutinib, it's kind of meant because these are daily continuous therapy. Maintenance is a part of it because you just keep taking the drug. So maintenance strategy with rituximab, CD20 antibody, has really not been pursued in the US, and I really don't think anyone is really studying that closely anymore.
Right. There is a question about India, whether CLL MRD is done as a routine in India. The answer is no, it is not done routinely in India. Is the higher secondary MDS and AML in elderly following FCR due to FCR itself or pre-existing chip?
Yeah, so I think that's a great question, and we and others are looking at it right now. There have been studies actually from our group and other groups as well, which have more looked at the solid tumor, breast cancer, lung cancer, whatever, and they're getting chemotherapy for that, and 5 years later they have an MDS and AML, so outside of CLL setting, where they have also shown that there is a pre-existing chip in majority of those patients, which then gets selected with the chemotherapy and become an AML MDS 5 years down the line. We are actually trying to look at the same argument for FCR treated patients at our center as well, and it is very likely that you will see some pre-existing chip mutations for the patients who have developed later MDS and AML.
The last question is, can you explain about FCR Lite?
So the FCR Lite, something we have not pursued, but groups in Europe have pursued, where basically it's light is low chemotherapy. So instead of 250 of cyclophosphamide, 25 of fludarabine, you may be using 15 or 17.5, some lower dose basically. And that's called FCR Lite. And the argument was that if you decrease the intensity of fludarabine and cyclophosphamide, that could be administered to patients above 65 years of age, where typical standard 6 cycles of FCR is not practical. Again, there were studies done. I think there are 2 or 3 studies which have been reported with FCR Lite with slightly different chemo doses. Again, those was published 4 or 5 years ago. Again, with less role for chemotherapy, those really have fallen out of favor. No one is really talking about them, doing them anymore. But yeah, certainly there is some data to lower intensity FCR, and that's called FCR light.
Thank you, Dr. Nitin. That was the last question. So this was a great evening for us and early morning for you. We have taken your 2 hours and you have done a great justice to the subject. Not only the formal talk, but patiently answered everything that we asked.
No, this was great, and I hope you enjoyed it, and looking forward to talking in some other format soon.
Yes, I must tell them that you are going to do Best of ASH with us.
Yeah.
Committed, yes, in January 3rd week, Dr. Nitin Jain has agreed to do Best of ASH with us. So you can wait for that to see him again, and maybe something in between, who knows. Thank you so much, Dr. Nitin.
Take care. Good night, everyone. Bye.
Bye. Thank you.